Let's just give it one more minute, then we can get started. We can get started. Attendance will keep climbing.
All righty, sounds good. Well, it is my absolute pleasure to introduce Dr. Emily Dzoba, who is an assistant professor of medicine in the Division of Allergy Immunology here at USF. She is a board-certified allergist immunologist, currently practicing at both the Allergy Asthma Immunology Associates of Tampa Bay and our James A. Haley Veterans Hospital. She completed her fellowship in allergy immunology here at USF, where she served as the chief fellow, and her residency in internal medicine at the University of Florida. She is an accomplished clinician. Sorry, I'm like trying to get rid of my alerts here. She's an accomplished clinician, educator, and researcher with numerous publications in leading journals, including the Journal of Allergy and Clinical Immunology. Her research interests include asthma, chronic rhinosinusitis, immunodeficiency, and innovative approaches to allergy care, which I believe we'll be hearing more about today. She has presented her work at national conferences such as AAAAI and ACAAI, and has received multiple honors, including the ACP Outstanding Resident Award and Summa Cum Laude distinction from the University of Florida. Please all join me in welcoming Dr. Dzoba to Grand Rounds.
Thank you, Dr. Matea. I'll go ahead and share my screen here. All right, can you guys see everything okay?
Sure can.
That's good.
All right. Well, good afternoon again, everyone. Happy almost Halloween. I'm going to be talking today about the stuffy, itchy, and runny nose. And it's not just allergies. So we're going to focus a lot on non-allergic causes of chronic rhinitis. These are my disclosures, not relevant to today's talk. So objectives, so we're going to broadly focus on the differential diagnosis for chronic nasal congestion and runny nose. We're going to talk about some different diagnostic and imaging modalities in evaluating chronic rhinitis. And at the end, we're going to go over a couple of example patient cases and looking at a couple of key concepts in diagnosis and management. So just some background information. As we know, allergic rhinitis is widely prevalent. It affects about 15% of the US population, which is about 50 million people. And it has a pretty significant impact on quality of life. So it can cause significant fatigue, even cognitive impairment, sleep disturbance. Absenteeism is a big problem as well with work and school, and impaired performance overall that really leads to increased cost burden, not only on medical system, but in society as well. But when we think about rhinitis overall, actually up to 25% of people that have chronic rhinitis have non-allergic rhinitis, and 50% of patients with rhinitis have a mixed etiology encompassing both allergic and non-allergic components. So it's important to be able to properly diagnose and classify patients' disease in order to optimize treatment for each person. So taking a step back, and what is rhinitis? So it's really just the presence of one or more symptoms, including nasal congestion, runny nose, and that can be anterior or postnasal drip, sneezing, and nasal itching. And when it's persistent over 12 weeks, that's considered to be chronic. So as I mentioned, there's numerous causes that can be classified as allergic, non-allergic, or mixed etiology. And there's also some distinct conditions that mimic chronic rhinitis due to significant overlap of symptoms. So we'll talk about some of those as well. And while the term rhinitis does imply a presence of inflammation, actually for numerous forms of non-allergic rhinitis, there isn't an inflammatory component associated with it. So you may also hear the term rhinopathy used in the literature as well. Just a brief overview of nasal anatomy as a reminder and some of the functions. So you have the nasal septum, which is the midline structure that divides the nose into two nostrils, and it's made of bony and cartilaginous components. Turbinates are structures that are made up of spongy bone, and it's covered by a mucous membrane. You have a set of 3 of them on either side of the nose. So you can see this includes the superior, the middle, and the inferior turbinate here. So the purpose of these is to warm and humidify and filter the air as we breathe in. It also can swell or contract in response to various stimuli. Nasal valves, so there are internal and external valves that are cartilaginous structures, and they help keep the nostrils patent rather than collapsing in when we're breathing in. There also is the nasal or the sinuses. So there are 4 different sets of sinuses: the frontal ethmoids, which are broken up into the anterior, middle, and posterior. You have the sphenoid sinuses more posteriorly, and then you have the larger maxillary sinus here. These are mucosal lined spaces, air spaces within the skull. And the function of, they have several functions. So one is to lighten the weight of the skull. They also contribute to filtering, warming, and humidifying the air like the turbinates do. They give resonance to our voice, and they're also lined with cilia that help with proper drainage of mucus throughout. And this is just a CT scan showing all of these sinuses as well. And you can get actually a side view of the turbinates here. So let's talk about the pathogenesis. So we'll start with allergic rhinitis. So this is our prototypical type 1 hypersensitivity reaction, or IgE-mediated inflammatory reaction. So you have environmental allergens that will get through the nasal epithelial cell layer, and they're met by antigen-presenting cells. So they're going to pick up these allergens and present them to naive CD4 T cells. This is going to lead to differentiation of the T cells towards a Th2 inflammatory profile, and that will help B cells to differentiate into plasma cells that produce allergen-specific IgE antibodies. And these antibodies are going to directly activate mast cells and basophils, leading to degranulation and release of inflammatory mediators. And when this occurs, you have both an acute phase response and a chronic or late phase response. So the acute or immediate is going to happen within minutes of this degranulation due to mediators like histamine, leukotrienes, prostaglandins, and others. That's going to lead to the acute allergic symptoms that we know, like sneezing, congestion, runny nose. And then when you have repeated degranulation, and you'll have continued stimulation and production of these cytokines that lead to recruitment of other inflammatory cells like eosinophils, and this will lead to this prolonged or chronic phase response and chronic allergic symptoms. When we talk about non-allergic rhinitis, as I alluded to, many of these don't have an inflammatory component and are actually mediated by neurogenic pathways. So you can see the nasal mucosa here. We have our ciliated columnar epithelial cells. You have submucosal blood vessels, and then our goblet or mucus cells. And then they're all innervated with sympathetic and parasympathetic nerves. So when you have mechanical or noxious stimuli, this leads to trigeminal nerve activation. When there's parasympathetic stimulation, this is going to lead to a vasodilatory effect, which is going to lead to swelling of the tissues and the sensation of nasal congestion, as well as mucus hypersecretion. When you have the opposite of sympathetic stimulation, this is where you get a vasoconstrictive effect, and the opposite being increased or improved airflow and decreased nasal cavity resistance. This is one of the primary mechanisms when we talk about nasal congestion, is that vasodilatory effect there. To complicate things further, the nasal mucosa also is lined with the noradrenergic non-cholinergic system. And when that's activated, it can release certain neuropeptides that can also directly activate mast cells and lead to very similar symptoms that we see with allergic rhinitis as well. So now we're going to switch gears and start talking about our differential diagnosis. So as we mentioned, kind of broadly, you can think about in terms of allergic rhinitis, which encompasses seasonal and perennial, as well as a condition called local allergic rhinitis that we'll talk about a little more. And then you have our non-allergic rhinitis, which encompasses multiple different diagnoses, and we'll talk about each of these. And then keeping in mind 50% of patients can have overlap of both. So we'll start out with our allergic rhinitis. So again, this is an inflammatory process. It's IgE mediated in response to environmental allergens. So when you're looking at history, you may see people that have just seasonal symptoms, a very clear recurrent seasonal pattern. For us in Florida, our main season for pollen is going to be the tree pollen season, which is going to be from January actually through May, so pretty long. Or you may have more perennial symptoms that are recurrent throughout the year, and that can be due to things like animal dander, dust mites, or even indoor molds. Symptoms are going to include runny nose, nasal congestion, nasal or ocular itching is a key factor in the history that's pretty indicative of an allergic component. And sneezing paroxysms, especially when they're occurring 4 or more in a row, can be pretty consistent with allergic rhinitis, and lacrimation can occur as well. So some physical exam findings you can keep an eye out for. In this image over here, we have allergic shiners. That's by the red arrow. You have Denny Morgan lines, which are these exaggerated folds here due to edema. And large nasal turbinates, which is not specific to allergic rhinitis, but it's something that's commonly seen. And then cobblestoning appearance of like the oral pharyngeal mucosa, which can be seen here. And these are patches of lymphatic tissue. So diagnosis obviously requires positive allergen skin testing or serum-specific IgE for environmental allergens. But in general, the history is one of our best diagnostic tools and has a positive predictive value of about 70%. And looking at each of these diagnoses, I'll briefly summarize what the treatments are, the focus, the talk being mostly looking at differential and key clinical findings, but I'll briefly touch upon it. There's a lot more detailed treatment algorithms that are available in our allergy practice parameters for those who are interested. But for allergic rhinitis, avoidance is key of trying to really avoid these allergenic triggers. Nasal corticosteroids, nasal antihistamines, or in combination, they can be used as well. Oral antihistamines, nasal lavages, and allergen immunotherapy can be used to desensitize them to their allergen triggers. So local rhinitis is, local allergic rhinitis is also known as entopy or entopic allergic rhinitis. So this is somebody who has a very clear clinical history that sounds consistent with either perennial or seasonal symptoms following allergen exposures. However, when you do allergen skin testing and blood testing, they're both negative. But if you were to directly challenge these patients with a nasal allergen provocation test or nasal allergen challenge, these will end up being positive. And so you can see on the right, this is an example of one technique for a nasal allergen challenge, with nasal allergen extract being placed on a paper disc that's applied to the turbinate surface. And then they're monitored for development of symptoms and other measurements, including airway resistance. And the nasal secretions can often have detectable specific IgE as well. There are multiple techniques for, doing these kind of challenges, but the biggest downside is they're not very widely available. They're mostly being looked at in research settings, but it does seem like something that may become more prevalent moving forward as this becomes more standardized. But for these patients, most of them are going to be monosensitized, most commonly to dust mites, but about a third of patients can be polysensitized. And the treatments are going to be the same as you would for regular allergic rhinitis. So getting into our non-allergic rhinitis, you can see kind of very broadly separated into those with a more neurogenic endotype versus inflammatory, with neurogenic being encompassing the vast majority of these diagnoses, but some may have a little bit of overlap. When we talk about the symptoms, you'll see the most predominant ones are going to be nasal congestion and runny nose or postnasal drip. It's very uncommon to see itching of the nose or eyes with non-allergic patients, and ocular symptoms in general are usually absent. And vast majority of these patients will either have symptoms all year round or seem to not really have a clear seasonal or timing pattern to it. All these patients will typically have negative allergy testing unless they are somebody that has a mixed picture. And it includes a wide range of diagnoses, the most common being vasomotor rhinitis, which is also referred to as idiopathic rhinitis in the literature. Onset is usually going to be in adulthood. So 70% of patients will present after the age of 20. And again, while some of them have an inflammatory component underlying, evidence does suggest that majority of forms of non-allergic rhinitis have neurogenic mechanisms, particularly an imbalance between those sympathetic and parasympathetics in its innervation and stimulation. And so the term neurogenic rhinitis has also been proposed for that reason to replace vasomotor or idiopathic rhinitis. So we'll start off talking about a condition called NAIRS, or non-allergic rhinitis with eosinophilia syndrome. So this is one that is an inflammatory type of non-allergic rhinitis. Overall, the prevalence is unknown, but it's estimated to be anywhere from 12 to 25% of non-allergic rhinitis patients. This is typically going to be a patient that has predominant symptoms of runny nose and sneezing in the absence of significant facial pain or sinus disease or evidence of nasal polyps. Nasal secretions will show predominance of eosinophils greater than 25%, and they will have negative allergy testing. The problem here is that current clinical guidelines have not really recommended routine assessment of nasal eosinophils, and there really is not a good consensus or on a specific diagnostic criteria for this condition either. So it's likely that many patients go under-recognized and underdiagnosed. But for this group of patients, they are particularly responsive to nasal corticosteroids, and there may be benefit potential from montelukast. Next, we'll talk about vasomotor rhinitis, our most common form of non-allergic, encompassing over 80% of patients with non-allergic rhinitis. So these patients will have intermittent symptoms that are an exaggerated reaction to different environmental irritants. So this can vary and include strong odors or fragrances like perfumes, smoke, or cleaning products. If you ever hear somebody say that they're allergic to perfume, it's likely not a true allergy. It is most likely this vasomotor rhinitis. Air pollution and irritants like car exhaust or diesel fuel, and temperature changes and humidity changes. So going from hot to cold or vice versa, but particularly cold, dry air can be a major trigger. This is typically a diagnosis of exclusion. There's no real diagnostic testing done to confirm this. But treatments can range, avoidance of triggers, obviously, nasal corticosteroids or antihistamines, but intranasal capsaicin actually has been found to be effective here. And the reason for that is on sensory nerves, there is a receptor called TRPV1 that is activated by these environmental irritants, as well as capsaicin. And so recurrent use of nasal capsaicin actually can desensitize these receptors with repeated use, so making them less responsive and then reducing symptoms when exposed to these different irritants because they're desensitized. And then lastly, posterior nasal nerve ablation can be considered, done by ENTs, and this will basically decrease the parasympathetic innervation that leads to the development of these symptoms. Next, we'll talk about infectious rhinitis. So this obviously can be acute or chronic, and it can range in severity from very self-limited, such as common viral upper respiratory infections, to severe disease with other pathogens, including bacterial or fungal. Symptoms can definitely overlap or mimic allergic rhinitis. And so looking at the history is important to try to find clues suggestive of allergic rhinitis. So this could be an obvious allergenic trigger, or nasal or ocular itching are a lot more specific to allergic rhinitis. You'll often hear people talk about the color of nasal discharge, but this is actually not very useful or sensitive or specific to distinguishing either form. Even distinguishing between viral and bacterial infections based on history is very difficult and often not possible. But most guidelines in general suggest deferring antibiotic treatment for 7 to 10 days to avoid overuse of antibiotics, as most viral infections will resolve by that point, and then proceeding to antibiotics if it's persistent or worsening. And for treatment refractory or recurrent, typically considering cultures to tailor antibiotics to those specific organisms can be helpful. And you'll also want to keep in mind unique populations that are susceptible to frequent or persistent refractory infectious rhinitis. So those that have anatomical abnormalities of the nose or sinuses, including significant obstructions, chronic rhinosinusitis with nasal polyps, ciliary dysfunction with that obviously have inability to clear mucus properly, leading to stasis and risk of developing infection, cystic fibrosis for similar reasons. Those with primary or acquired immune deficiencies, just unable to fight off these infections, and pediatric populations are also very susceptible. Next category is going to be food-induced rhinitis or gustatory rhinitis. So main symptom that comes up in the history is going to be clear rhinorrhea, typically after food ingestion, especially with hot or spicy foods, but this can happen with any kind of food exposure. So this is a vaguely mediated process. It's a neurogenic reflex parasympathetic response that leads to these symptoms just by the act of eating. And there's no evidence that there are IgE-mediated food-induced rhinitis symptoms without having other systemic symptoms, including anaphylaxis. Therefore, there's no indication to test for food allergies when you're evaluating these patients. Alcohol-induced rhinitis is also common food-induced rhinitis. Most common symptoms are going to be nasal congestion, followed by runny nose. And this is due to an alcohol hyperresponsiveness, including vasodilatory effects, and it's not considered to be an alcohol allergy. This can occur in 14% of healthy adults. more common in asthmatics in about a third of them, and then even more common in those with AERD or aspirin exacerbated respiratory disease in about 75%. The treatment for this is going to be ipratropium bromide, which is a nasal anticholinergic spray, and this can be used prophylactically prior to eating. It can also be used in combination with a nasal corticosteroid if it's ineffective in itself. Next, we will talk about hormonal rhinitis. We'll start with talking about pregnancy specifically as one form. So the hormonal changes we see in pregnancy result in symptoms in about 20 to 40% of women. And this onset can occur anytime during gestation, but most commonly it's seen between weeks 13 to 21. And the symptoms will completely resolve within 2 weeks of delivery. But it's important to note that while this does come up, the most common cause of rhinitis in pregnancy is still going to be allergic rhinitis. And why does this happen in pregnancy? The associated hormones lead to vasodilation and expansion of the blood volume. So increasing blood pooling in the nasal vasculature. So you can kind of see this pattern. Vasodilatory effects are going to lead to nasal congestion. Treatment. First line, non-pharmacologic treatments are going to be prioritized. So elevating the head of the bed, using external nasal dilators like the adhesive nasal strips that go on the outside, use of saline rinses, and even light exercise can be helpful. But if symptoms are persistent or more severe, you can consider budesonide nasal corticosteroid spray, which is considered category B in pregnancy. Other causes of hormonal rhinitis, so this can occur during the menstrual cycle, in perimenopause, and puberty due to changes in estrogen and progesterone levels. So as we talked about, estrogen can lead to vascular engorgement and nasal congestion. But interestingly, estrogen and progesterone can increase eosinophil migration into the nasal mucosa, whereas testosterone has the opposite effect and decreases eosinophil presence. So it's thought that this could account for female predominance of rhinitis that occurs after puberty. Some other hormonal conditions to be aware of: hypothyroidism is rarely associated with chronic rhinitis, and this can be because increased TSH release can lead to turbinate swelling. And then other endocrine diseases have been associated, such as acromegaly. Drug-induced rhinitis. So many common medications we see in our patients have been implicated in chronic nasal congestion through local varied reasons. Some of them are due to inflammatory effects. Some of them are neurogenic. Many of them we don't really know why. But again, often this is going to be isolated nasal congestion. And treatment is going to be limiting the offending agent if possible. But again, this kind of highlights the importance when we're evaluating patients with chronic nasal congestion or rhinitis for doing a thorough medication review with the patient to see could they be taking any medications that are possibly contributing to their symptoms. So kind of just briefly, some of the ones that are commonly implicated: aspirin and NSAIDs, which have more of an inflammatory type of mechanism. Alpha blockers like clonidine, prazosin, methyl-dopa, and this is neurogenic effect. Beta blockers, also neurogenic effect, and this can include both oral and ophthalmic. Other antihypertensives, some of these are because of a vasodilatory effect, but others it's not fully clear. But this can include ACE inhibitors, calcium channel blockers, hydralazine. Oral contraceptives or exogenous estrogen for the reasons we just talked about before. Phosphodiesterase inhibitors, which are the purpose is vasodilatory effect, so that could certainly cause nasal congestion, and that can include sildenafil, tadalafil. And other psychotropics and anti-epileptics have been associated too, many of them for unknown reasons, but risperidone, some benzos, chlorpromazine, and gabapentin. Rhinitis medicamentosa, this is another form of drug-induced rhinitis that is from the overuse of nasal decongestants. So oxymetazoline, phenylephrine, and even cocaine are all alpha adrenergic agonists. And so they are powerful vasoconstrictors that will reduce mucosal swelling because of the vasoconstriction and therefore reduce nasal congestion. So they work really well as they're very good for acute decongestant. However, the problem is with repeated and prolonged use, you'll get this alpha receptor tachyphylaxis. So this is going to desensitize these receptors. It requires more and more of the medication to be effective, but you get this rebound or worsening nasal congestion when these receptors are not working as well. So you're kind of creating this vicious cycle of using more of it, causing more tachyphylaxis, causing rebound congestion. That makes you want to use more of it. So it's kind of a vicious process there. But time to onset is very variable. It can be after days of using it frequently, but for some patients, it can take over 6 weeks to develop any kind of signs of this. And you can see the images on the left here kind of highlight this is normal or healthy mucosa here. And this is, you can see very engorged and inflamed mucosa from this chronic use of these decongestants. There have been double-blind placebo-controlled trials in allergic rhinitis that have shown that concurrent administration of a nasal steroid with oxymetazoline once a day up to 4 weeks actually prevented the development of rhinitis medicamentosa. So in some patients with very refractory symptoms, this is a consideration. Again, still with very sparing use of it, that nasal corticosteroids may help prevent the development of this. But once this does occur, though, the treatment is to stop the nasal decongestant. And unfortunately, a lot of these patients are going to be miserable with these kind of symptoms that can often take months to resolve. And you can consider using a nasal steroid to help mitigate those symptoms. Next, we'll talk about atrophic rhinitis, which is also known as empty nose syndrome. So this is a progressive atrophy of the nasal mucosa, and that leads to loss of the normal secretory as well as humidifying functions within the nose. So very typical symptoms, you'll have this paradoxical sensation of nasal congestion, even though when on exam and imaging, you'll see they have very widened nasal passages. And that's really thought to be due to this just decreased ability to sense the airflow when you have just these atrophied structures, so it feels congested to them. There's also a typical nasal crusting with thick yellow-green crusts that can be seen, and patients will often complain of detecting a foul odor or even loss of sense of smell. And it's associated with bacterial infections as well, as you can imagine, and the most common being Klebsiella ozonae. This condition is more common in females, particularly elderly, and those that live in dry, arid climates. And this can also be secondary to several different things. So those that have had multiple nasal or sinus surgeries, radiation therapy, if they've had nasal trauma, or those that have granulomatous disease, these are all possible secondary causes. But management is going to be aggressive saline irrigations to hydrate the mucosa to help it heal, antibiotics for treatment of infections. Some patients may require additional surgery to assist with healing of the nasal mucosa, sometimes through use of a variety of implants to help narrow the airway as well. This is an endoscopic image of somebody with atrophic rhinitis. So you can see very widely patent airspace here. This is also on the right-hand side a significant septal perforation, which can also be seen due to the significant atrophy that occurs. and you can see into the other side there. And this is the typical yellow-green thick crust that can form. This is a CT scan of somebody with atrophic rhinitis, and this is a normal CT for comparison. You can see, the healthy, normal-sized turbinates that really do fill a good amount of the space here, but you still have a patent airflow space. But on this side, you can see really almost completely gone, and then very wide open space here. That's very typical with atrophic rhinitis. The next, we'll talk about CPAP rhinitis. So patients that use positive pressure devices can develop new onset of nasal symptoms. So this is likely thought to be due to damage to the nasal mucosa from cold, dry air that's pressurized. Common symptoms are nasal congestion, can have dryness as well as crusting as well. An exam often can show dry and even erythematous looking mucosa. Treatment is going to be use of saline irrigations, and then making sure they're utilizing the warming and humidifying functions on their PAP devices. Small amounts of petroleum jelly can also be applied to the anterior nose to help. But in terms of like medicated sprays, there was a randomized trial of 63 patients that did not find any benefit to use of nasal corticosteroids, but again, pretty small sample size, so maybe something that needs to be looked into further. So last, we're going to talk about a couple of other conditions to keep in mind that can overlap with symptoms of chronic rhinitis. So obstruction is something we always look out for. So turbinate hypertrophy. Now, this in itself is not necessarily like a primary diagnosis. This can be secondary to other causes of mucosal inflammation or irritation, such as allergic rhinitis. So seeing this on exam really should prompt further, investigation into what could be causing it. Nasal septal deviations. So these are very common in the general population, and typically they're going to be mild and pretty well tolerated for most. However, more moderate to severe deviations, especially that have an associated turbinate hypertrophy, can cause significant obstruction and may require surgery. So this is a good diagram example of a significant right septal deviation that's impinging upon the turbinates and reducing airflow. And then on the left side, against the deviation, you have inferior turbinate hypertrophy that's also abutting up against the septum that can be causing pretty significant congestion. Tumors is always something we look out for, whether they're benign or neoplastic. Classically, we'll see usually unilateral nasal congestion or even bleeding, but always something to keep on your differential. Nasal valve collapse that's seen in this photo here. So as we mentioned, those kind of cartilaginous structures should normally help keep this patent when you're breathing in, but for some people, they can have this abnormality where they breathe in and those kind of the outside of the nostrils will collapse in on themselves and obviously cause you to feel congested. Lastly, adenoid hypertrophy is also something that can cause significant obstruction depending on how severe it is. Nowadays, a lot of pediatric patients end up having these removed alongside of tonsillectomy, but there's still many people that they don't end up having those adenoids removed. Usually they'll kind of present with almost like an obstructive sleep apnea type of picture. So they may have snoring, significant nasal congestion as well. So this is something that can be seen on imaging or even nasal endoscopy, may require surgical reduction. Next, we have chronic rhinosinusitis. So this topic in itself could easily fill one or multiple lectures, but it is always on our differential when we're evaluating patients with chronic nasal complaints. So you can see there is an overlap of symptoms with rhinitis and rhinosinusitis. With rhinosinusitis, more commonly, we'll see more complaints of headache or facial pain or pressure, alterations in sense of smell, including the loss of smell, and purulent drainage are things that may be clues for chronic rhinosinusitis, less commonly itching or sneezing. Now, rhinosinusitis, it's inflammation of both the paranasal sinuses as well as nasal mucosa, and it's due to a disrupted epithelial barrier function that leads to dysregulated chronic inflammatory response. Broadly, it's differentiated into two phenotypes. So rhinosinusitis with and without nasal polyps. You can see on the right, that is an example of a nasal polyp on exam. Diagnosis is made by clinical history requiring at least 2 or more symptoms and evidence of sinonasal inflammation on CT scan or endoscopy. So treatment is going to include a combination of nasal steroids, saline rinses, may or may not require surgical intervention depending on severity and response to medical treatment. And for those with nasal polyps, there are biologic therapies now targeting the T2 inflammatory pathway that is approved for treatment of nasal polyps. CSF rhinorrhea, so this is a mimicker of rhinitis. So this is due to a leakage of CSF that can come out through the nose. Usually the characteristic clinical trait is going to be clear rhinorrhea from one side. It may or may not be blood tinged, but there's no evidence of mucosal inflammation. Most commonly, this is going to be in the setting of trauma, but it can occur as a complication of surgery as well. And typically this will be within 48 hours of a trauma, but can be delayed even up to 3 months too. You'll see on the left, this image is depicting the halo sign. So this is if collecting of the nasal discharge on like a filter paper, and you'll see that the blood that's tinging it will stay kind of central. It doesn't spread as far, but the CSF will extravasate further out, and that creates this kind of halo effect. But the gold standard for distinguishing nasal secretions versus CSF is going to be testing that secretion for beta-2 transferrin. Next, we have laryngopharyngeal reflux, or LPR. These patients are often going to present with symptom of postnasal drip, typically throat clearing or cough, and it's a result, obviously, of acid reflux into the larynx and pharynx. So they may or may not complain of noticeable esophageal or reflux symptoms, but typically when they are having this degree of like postnasal drip or throat clearing, they often will have reflux symptoms as well. You can see evidence of this on direct rhinolaryngoscopy. That's seen here on the right-hand side. So the top photo is showing nice, healthy mucosa and very clearly demarcated structures here, but this is a pretty severe case of LPR where you have this intra-arytenoid pachydermia, all this swelling and inflammation that's occurring and really kind of blurring the structures occurring there. So treatment is going to be treating the underlying reflux, diet modification, and PPI. You always want to keep in mind systemic diseases. So the nose and sinuses can be involved in a variety of different systemic inflammatory diseases. Obviously, they're going to present typically with other systemic symptoms due to involvement of other organ systems. But ones that can be implicated include autoimmune diseases like lupus, Sjogren's syndrome, which is called rhinitis sicca, EGPA. Common feature of that is chronic sinus disease and relapsing polychondritis due to the breakdown of cartilaginous structures, which are prominent in the nose. Granulomatous diseases like GPA and even sarcoidosis. We actually had a patient in clinic this week with nasal sarcoid, so it does come up rarely, but it does come up. All right, getting into the home stretch, we're going to briefly talk about some diagnostic testing. So allergy skin testing, this is specifically talking about for environmental allergens. So skin testing is a bioassay that detects the presence of allergen-specific IgE on patients' mast cells. So allergen is introduced into the skin where it comes in contact with the cutaneous mast cells. If allergen specific IgE is present, mast cells will be degranulated and you'll get a wheal and flare response. For this test, a positive and negative control is also used to make sure it's valid. So the positive control is going to be a histamine solution. Negative control will be the diluent that the allergenic extracts are mixed in, which is typically a glycerinated saline. So the pros of this testing, it's very rapid. You'll get results immediately. It's cost effective and it's safe, minimally invasive, and it is more sensitive and specific than serum or in vitro testing. So 85% sensitive and 77% specific. The cons is that patients will need to hold certain medications, including many of their allergy medicines and antihistamines, up to a week ahead of time. It may not be accurate in those that have dermatographia or other skin conditions, and obviously it requires referral for specialists to perform the testing. But it's important to note that positive allergy testing by itself is not sufficient for diagnosis. It only indicates that they're sensitized to those things. So it must be supported by, a consistent clinical history of reactivity to those allergens. So this is what skin testing looks like. You'll have the allergenic extract is dropped on the skin, and a small device is used to prick it into the skin where it can come in contact with those mast cells. And then we look to see if a reaction develops. These are the devices we use. So this is what's called a multi-prick device that we use very commonly in children, just to kind of get them done pretty quickly at once. Whereas this is a single prick device we use for most of our older and adult patients. And this is an example of somebody, sorry, it's kind of a blurry image, but somebody that's had quite numerous positive allergen testing here and pretty angry back. Talking about in vitro or blood testing for allergies. So this is a serum immunoassay, and that's going to detect the presence of circulating allergen-specific IgE in the serum. So the pros of this is that it's widely available. A specialist isn't needed to perform it, and patients don't need to do any preparation ahead of time. They don't need to hold any of their medications. But the downside is that it is more expensive. It's less sensitive than the skin testing. So skin testing is the preferred method, and it takes longer to get the results. So often about a week or so for it to process. Compared with skin testing, serum testing provides information about the current production of the specific IgE, and circulating IgE, the half-life of that is about 48 hours. So you can definitely see there's a variation in this over time. But when you talk about skin testing, this is detecting IgE that's produced over a much longer period. So once it's bound to mast cells, they can remain there for at least 2 years. So it's kind of interesting difference in what you're picking up there. When we talk about imaging, so this is looking for evidence of mucosal inflammation as well as anatomical deformities. So CT sinus without contrast is going to be our primary imaging modality. Plain films or x-rays lack sensitivity and specificity and generally are not very helpful. MRIs are also very good. They allow for a more detailed soft tissue assessment, especially if there's concern that disease is extending outside the sinus cavities. However, there is thought that they could potentially be too sensitive, leading to overdiagnosis, and obviously there's much higher costs associated with them. So in general, CT is preferred. These are just some example of CT scans with abnormalities. So the top image, you can see this is mucosal thickening or inflammation that's occurring in the right maxillary sinus. You can also see similar thickening on the left, and then there is an obvious air fluid level here that could indicate an acute infection. This bottom image, so you look at the maxillaries, you don't see quite any mucosal thickening or inflammation there, but within the nose itself, you can see a pretty significant septal deviation to the right. And then on the left side, you have inferior turbinate hypertrophy. And then this whole structure is the middle turbinate that's pneumatized. And this is called concha bullosa, where there's air in the turbinate. And that can cause it to be enlarged and cause significant nasal congestion or obstruction. Rhinolaryngoscopy, so this allows for direct visualization of the nasal cavity, the pharynx, and the larynx. It's a very quick procedure. It can be done in the office in less than 10 minutes. There's minimal risk to the patient, and it limits their radiation exposure as well. So you can look for a number of things, looking for patency of sinus ostia when it's possible, as well as like surgically created openings to make sure those are patent. Purulent drainage, you can look for evidence of LPR or paradoxical vocal fold movements, so that's useful for evaluating chronic cough. It's helpful for diagnosing nasal polyps, and nasal polyps are not always seen on CT scans. It's not very sensitive for them, so often they require rhinoscopy to see them. You can use it to obtain cultures and really just look for any other evidence of obstructions as well. So this is what a typical flexible rhinoscope looks like. This image kind of shows you the different visuals you'll see as you go through, but basically it's inserted through into the nose, and you can pass it easily down into the nasopharynx and oropharynx as well. And this is a typical like nasal endoscopy view, and this is a nasal polyp that's seen on exam. All right, kind of the home stretch here. We've got 3 quick practice questions and cases we can go through. So I'll just read them out. But so the first one, we have a 57-year-old male who presents with a chief complaint of food allergy. So he reports having episodic, clear, runny nose that occurs when he eats. There's no other systemic symptoms. It occurs with nearly all meals, so he's not sure what food it is that's causing the symptoms. His physical exam is largely unremarkable: moist pink mucosa, no visible obstructions, no turbinate hypertrophy, and no visible drainage. So what would be the next best step in management? Would you do CT sinus without contrast, allergen skin testing for common food and environmental allergens, trial of ipratropium bromide spray before meals, or referral to ENT for posterior nerve ablation? So the answer for this one is going to be trial of ipratropium bromide, the diagnosis being gustatory rhinitis, kind of the key points in the question stem being just clear discharge occurring while eating without other systemic symptoms, and there's not a specific food trigger. It's happening with all meals that he's eating. So this is going to be that typical gustatory rhinitis. Our next case, so we have a 72-year-old female presenting for concern of refractory bilateral nasal congestion. This is the main symptom, but she has also noticed some occasional bleeding and a foul smell intermittently. She has a long-standing history of nasal and sinus disease and has had multiple surgeries, including inferior turbinate resection, middle turbinectomy, septoplasty, and functional endoscopic sinus surgeries ×3, only with temporary improvement in her symptoms. And her physical exam is shown here. So what would be the next best step for this patient? Start saline rinses, perform allergy skin prick testing, start a combination of nasal steroid and antihistamine, or refer to ENT for a revision turbinate resection. So this answer is A, start saline rinses, and this is a diagnosis of atrophic rhinitis. So this is an elderly female, so it's more common in that population. She's had multiple surgeries, and you can see on exam, almost can't even see the turbinate structures. It's very widely patent, and she has that yellow-green crusting there. Also, foul smell is another key term as well. So very typical atrophic rhinitis patient. This is our last case. So we have a 64-year-old male with a history of hypertension, anxiety, BPH, and type 2 diabetes who presents mostly with bilateral nasal congestion. He has occasional mild postnasal drip, and these symptoms have been going on only for the past year. No itching of the nose, and his sense of smell is intact. It's present. His symptoms are all the time. There's no change with seasons, temperature, time of day, no difference between indoors and outdoors. He does have a cat and a dog at home. He's had them for several years. He's tried nasal steroids, saline spray, multiple oral antihistamines without benefit. He has no other symptoms and reports his chronic medical problems are otherwise well controlled since starting several new medications last year. His physical exam shows mild turbinate hypertrophy bilaterally with erythematous mucosa. Septum's midline, no visible lesions, polyps, or crusting. So what would be the most likely diagnosis for this patient? So the answer here is drug-induced rhinitis. So a couple of clues in the question. He's got multiple, comorbid concerns, hypertension, BPH, anxiety. All of these are associated with medications that can cause nasal congestion. And he reports starting several new medications last year, and his symptoms have been around for about a year. And there's no clear variation with exposures, so unlikely to be allergic. He's tried multiple things that really haven't helped, and just has that mild turbinate hypertrophy and erythematous mucosa. So this is someone you'd want to do a thorough med rec with them and see if there's anything that could be contributing. All right, so that's everything. These are my references. But thank you for listening. I'm happy to take any questions.
Thank you so much for an incredible presentation. Really appreciate it. Very easy to digest, and I learned several things. Does anybody have any questions? It's a quiet one today. All right. Wonderful. Thank you again so much for taking the time to give us that fantastic presentation. I personally have to jump off as I have to do some interviews here in a couple of minutes, but I'm sure Jen can kind of continue to manage the chat in case other questions do roll in. But thank you so much, Emily. Appreciate it.
Thanks, Dr. Matea. Take care.